Hello there, everyone. Happy to have you here. Welcome to Perfecting PT. Today, I am joined by Anthony Falco. And just kind of to give you a little overview, our big plan for today is to talk about cervicogenic headaches, which if you're like me, you're really looking forward to because you don't actually know that much about it. But I'll kind of turn the time over to Anthony, to introduce himself and we'll get going. So thank you again, Anthony, for being here and welcome.
Yeah, for sure. Thanks for having me. So
Absolutely.
I'm Anthony Falco. I am from New Jersey. I work for a large multi-specialty group called Summit Health, and I'm currently the manager of the department. So I oversee about 40 clinicians and then treat a caseload myself. So I've worked in outpatient orthopedics for a little over 10 years now. And in that time, I've completed residency training. So I have my OCS, and last year graduated from fellowship training in manual therapy through the Bell College program. And the cervicogenic headache topic really over the last 3 years in my current position, my current employer, is where I've worked with a ton of patients with cervicogenic headaches, and I've gotten a lot of reps under my belt in an area that I feel like sometimes it seems a little bit complicated, but through fellowship training experience and just where I'm at in my career, and I've had the opportunity to get a lot of reps in, I feel like hopefully we can demystify some of that stuff today. So that's what I'm excited to be on and talk about. And the other part of my background is I'm involved at state level APTA stuff. So I'm currently the vice president of APTA New Jersey. And so I love all things physical therapy and supporting the profession. And I'm excited to be here and talk shop.
Excellent. Yeah, dude, again, thank you. Happy to have you. Because I believe if I look back kind of at our conversation, I welcomed you when you kind of followed the page back in December, and you were like, I'd be happy to come on. And I was like, excellent. So for those of you guys who are listening, again, this is just about a community of people that if you have something to offer, come on, because I think you do. And I think PT will be better if you share your expertise with the world. So thank you again, Anthony, for coming on. And I got to ask, because I've had 3 people from Jersey on here, and I've heard there's a pretty big idea of North and South Jersey.
Sure.
So are you from North or Southern New Jersey?
I am definitely from North Jersey. So I am solidly in the North Jersey area. I'm about 40 minutes west of New York City.
So I know we're going to talk about cervicogenic headaches, but now I'm curious. What is the difference between North and South Jersey?
You've got Giants, Yankees, Mets fans. And then in South Jersey, you're Phillies, Sixers, Eagles. So that's a big dividing line. Is kind of where the TV providers change if they offer, Giants versus Eagles broadcasts. To me, that's kind of the separation, but you can go online and find all kinds of other arguments for different sections of Jersey. Some people in Central Jersey argue that there's a Central Jersey. So it's a very New Jersey thing to be from the North or the South, or maybe in that kind of weird middle ground in Central Jersey. So, but it's one of the things that makes our state great.
Well, good to know. Thank you. So going into cervicogenic headaches, I guess what I would like to know is why don't we just run it? We'll kind of organize the conversation as an evaluation.
Sure.
And any tangents or spinoffs or any other things we chat about, we'll gladly follow those along. So
sure.
If a patient comes to you and they're talking about headaches, because when I think headaches, I often think of tension headaches. Because people are really tight around their suboccipitals, they're stressed, they're kind of locked up. Are those a subcategory of cervicogenic headaches, or are they the same thing? I guess I would like to know, what is a cervicogenic headache?
Sure. So the easy thing about cervicogenic headache, as with a lot of our anatomy terms and medical terms, is the name described exactly what it is. So cervicogenic, generated from the neck. Typically, a classic cervicogenic headache is going to be unilateral. It's typically going to start or be aggravated with specific neck postures or movements. And you're going to get that kind of classic ram's horn pattern, just meaning it kind of like starts in the back and wraps its way around, and it can settle in kind of temporal or even into the forehead area. That's your kind of classic textbook description of a true cervicogenic headache.
Mm-hmm.
Tension headaches are their own kind of classification or category of headaches. So that we're going to see more like bilateral temporal symptoms. It still can absolutely be associated with postures and positions, as well as stress levels, but they are technically two distinct categories. But what I'd say from my experience in treating all different types of cervicogenic headaches, or headaches that have components of cervicogenic pieces to them, or have a cervicogenic trigger, that I've treated different components of migraines, of cluster headaches, of tension headaches, of cervicogenic headaches with a well-rounded physical therapy, manual therapy approach. So yeah, there's a couple different descriptors out there and categories of classification for headaches. But yeah, those are some of the hallmark signs and the differences between those two particular ones, cervicogenic versus tension.
And how much of a contributing factor do you think the neck is to headaches in general?
I think it is very commonly a part of the pie. Even with things like migraines, where certainly there's no evidence, and in my experience, like, I'm not going to cure somebody's headache with physical therapy intervention if it's truly a migraine. But sometimes if there is a cervicogenic trigger or an additive effect of the cervical spine being restricted in mobility, or muscle imbalances or tension and tightness, that then can contribute to the severity or the length or the duration or frequency of migraine episodes being more. Like, sometimes we can help with manual therapy and physical therapy to decrease the frequency, intensity, duration of migraine episodes, even though we're not going to necessarily solve the migraine problem, if that makes sense. Yeah,
no, that makes a lot of sense. So going into, I like that it sounds like you use manual therapy, which would explain why you're a fellow of manual therapy.
Yes.
So I guess when it comes to like your guiding principles around cervicogenic headaches or the cervical spine as a whole, I heard you mention things about like a muscle imbalance.
Sure.
Like, what are your kind of beliefs about why people, like, why does the neck develop, for lack of a better word, like dysfunctions that lead to or contribute to headaches? Like, are there underlying things that you see regularly in your assessment or in what people tell you?
Sure. So I think a little, I'm going to give you just a quick background on kind of like my practice setup, because I think it'll help set the stage for a lot of what I see. And then I'll talk a little bit about some other factors as well. So in our clinic, we work very closely with a pediatric neurologist who spends a lot of time coming back into our PT clinic, which is awesome because he's very engaged with us and involved with us and collaborative with us in especially managing some of these patients. So he sees a lot of from as young as 4 or 5 through middle school, high school, and he sees young adults and adults as well. A lot of times we're seeing like a post-traumatic cervicogenic headache, and I use that term purposely because he is going through his screening and his perspective as a neurologist in kind of ruling out head injury, mild TBI, concussion, and going through his neuro exam and then getting them into physical therapy very quickly, sometimes same day, sometimes next day, or within a few days. And we're able to get hands on these patients, assess these patients, and then treat them quickly. And the fun part about that is we typically get a very rapid response to treatment if all of our diagnostics, point towards cervicogenic source of symptoms, and be able to have a really cool, quick effect on these patients, which makes it a lot of fun for us. And it's always impactful for the patients that way. So there's, to bring that back to answering your question, one of the things I see is, mild whiplash type injuries in sports where a kid might get hit and not actually hit their head, but they get kind of whipped around or collide with another player on a basketball court going up for a rebound, or take an elbow to the back of the head, or a wrestler gets slammed to the mat, or a football player, jams their neck up a little bit when making a tackle or making a hit. And that these are all very common mechanisms of injury that we'll see in the clinic, and then manage the cervicogenic portion of their presentation through working closely with our physician colleagues. So that's one big chunk of my experience in my practice for sure. Then the other thing we see is that's not all we see. We certainly then will see some of like postural related things. So every year over the last few years, early in the fall, when kids go back to school and maybe they haven't been sitting in front of their Chromebook for 8 hours during the day, and now they are, where there's like these postural strain headaches that start to set in, where, you know, they go from playing around, doing sports, doing camps and things all summer, and now they're sitting in class and they start to develop these complaints of headaches. And so those are ones where sometimes we'll just see like, yeah, they were fine all summer, and then we went back to school, and for a few weeks, you know, he started complaining of headaches, and now they're becoming more frequent and more severe. And so we brought them to the neurologist because we're very concerned. And so we see a lot of that like kind of postural strain stuff as well, which I've also seen a pattern with just the post kind of COVID era, where everybody from 2020 to 2023 or so, maybe was like working from home or working virtually and spending a lot more time on laptops. I feel like that's also a trend that I see, where the posture can become a little bit of an issue, and basically just like the lack of movement during the day, especially in some of my older patients that I see, and I'm talking about our college students who are cramming for finals and studying for the end of the semester, where they start to develop headaches around these times when they're not moving as much, and there may be some added stress or some added pressures of preparing for exams and these things. And so I think that there are lots of those different kind of factors that can start to contribute to why somebody may develop a cervicogenic headache. And they can work both ways, where you have a student who goes back to school. Now they're spending a lot of time sitting in class and maybe in not optimal positions, or not a lot of variety of movement and positions for their head and their neck. And then they go out and play sports and get bumped, and they develop some stiffness in their neck and a headache. So in my practice, that's what I see a lot of.
Awesome. So for anyone who kind of may have got lost in the sauce in that one, it looks like some common things to look for if someone is coming to you or presenting to you with either neck pain, headache pain, is, you know, any type of like low grade whiplash. You know, they got jostled playing a sport, they got, you know, tackled by their brother, you know, they play football, they take, you know, they kind of tweak their neck on a tackle. A soccer player may head the ball, kind of just, you know, anything that may just kind of set off the neck, to just not to you know, create some small level of dysfunction that can contribute to the headache, as well as sudden changes in postural positions. Maybe like Anthony said, someone is suddenly sitting a lot more. They are, you know, that could be at the beginning of a school year, at the end of a semester. Someone has had a sudden large work project where they were sitting down just cramming stuff, so they're not only not moving as much because they're sitting there trying to get stuff done, they're staying in these maybe suboptimal postures for extended period of time, with increased levels of stress that can all be contributing factors to why the neck is beginning to contribute to headaches.
Sure.
And so how often, like, I guess, is there a normal amount of headaches that someone should have, or are headaches always an abnormality?
I think there's certainly, I don't have the prevalence right off the top of my head, but I think everybody experiences a headache, right, at some point. I think, and there's tons of different factors that can contribute to it. You could have a cold, you could be sick, you could be dehydrated, you could have low blood sugar, right? There's 100 different reasons why you could have a headache. And some of those could be cervicogenic, postural, muscular, myofascial related reasons for having a headache. So I think that that's part of the examination process, and part of the subjective exam, right, would be like asking those kinds of questions and trying to rule down some of the non-musculoskeletal factors and try to prove to ourselves that, okay, there's some musculoskeletal things here that we would be able to work on, right? So I think, you know, when we think about all the different things that contribute to or cause a headache, or all the reasons a person could have a headache. Just because they have a headache doesn't mean it's coming from their neck. That's all part of like going through the exam. Sure.
No, correct. Yeah, no, for sure. Obviously, there are other reasons that people have headaches. I guess I need to be better about my question. Like if someone comes to me and they're like, oh, it's just normal for me to get headaches 3 days a week. Like at what point are you like, no, like it's not normal to have headaches that often. Like at what point, if someone says they have X amount of headaches,
Sure.
and maybe this isn't even patients, maybe this is just for people who happen to listen to this podcast.
Sure.
Like if you're having headaches, like how often are you having headaches that you would consider like too often, and you're either dehydrated, you need to get checked out, or you need to see a PT?
Yeah, I mean, I think anything that's happened on a regular basis, right? If it's happening 2 or 3 times a week, I think, and if there's a pattern to it, especially, right? And this is part of where my brain goes thinking about the exam is like, hey, is that happening consistently first thing in the morning? Is it happening consistently after you've been working on your laptop for a couple hours? Is it happening consistently after your drive to work if you get stuck in traffic and it's an hour and a half? And those days when you hit a bunch of traffic and your commute is 15 or 20 minutes longer than normal and it's stressful and you're running late to work, that might be causing some tension, some tightness, some adverse pressure on joints and mechanical structures that are contributing to or causing a headache. How long does the headache last? What does it feel like? How would you describe the headache? Those are all the details that would help me kind of work through with someone to determine like, okay, well, A, what do we think the source of this headache is? Is it something that we can manage? And if somebody's having headaches on a frequent basis, like 2 or 3 times a week, and we can spot a little bit of a pattern there, then we can dive into examination and try to figure it out. But I don't think anybody should be having headaches on a regular basis 2 or 3 times a week.
Okay, good to know. So we've already brought up like cervicogenic headaches, tension headaches, cluster headaches. I guess to be really concise, can physical therapy help all types of headaches to a certain degree? Like obviously some more than others, but like, okay, let me rephrase that question. I already know the answer. I thought about it. I heard it. It was a bad question. If a headache is not brought on by illness, dehydration, like, or other kind of non-musculoskeletal things, like what presentations are you listening for that in your head you're like, heck yeah, I'm going to be able to help you? Yeah. Does that question make sense?
It does make sense. I think the ones that the things that I'm listening for and asking for and trying to find those patterns in the subjective examination are if their location of symptoms matches with what I would expect to hear from a cervicogenic presentation.
Which again is unilateral ram's horn with specific motions.
Correct. And then from a description standpoint, throbby, achy, pressure, squeezing, tightness, changes with movement. So if they say like, yeah, if I turn my head this way or I try to look over, I just feel like I can't go very far. And if I feel that kind of radiate up into my head, like those kind of very mechanical and movement based factors are the things where in my head, I'm saying, all right, we got this. Like, let's get in there and let's do our screening and make sure we're not missing any red flag type conditions and that it truly is appropriate for PT care. But those are the things I'm listening for to say, oh yeah, we're going to have something to work on here for sure.
Cool.
Finding those mechanical pattern. Yep.
And is it the same with, so obviously, so that's a very specific, like textbook cervicogenic headache. We talked about how like tension headaches are like bilateral, but they can also be helped with physical therapy. Maybe the better question is what things are you listening for where you're like, I don't think therapy is going to help, or you need to be looked at by someone else?
Sure. No, and that's a perfect answer, because that for me is where my subjective exam kind of really starts from, is once I get the description, the location of the symptoms, the severity of the symptoms, how irritable the symptoms are, what our AGs and EASes are. Those are all the things that I'm listening for, A, to understand how their symptoms behave, and then B, to be able to start to go through my hypothesis generation process and rule down my red flag hypotheses. So things like, this is a headache I've never experienced before. I've never experienced anything like this before. It's a real sharp, stabbing, intense headache that is not helped or changed in any way by postures or movements. typically a lot of my patients will say, hey, if I lay down and support my neck and close my eyes, like it helps my headache feel a little bit better. If I take, let's say they take an Advil, or they use a heat pack on their neck and it helps relax their muscles and that provides them some relief. If they can do things that help provide some relief, to me, that's a sign that, like, okay, if you're doing things that have a specific effect and it is helping your symptoms, then I'm leaning more towards this is more likely musculoskeletal in nature. And if you're doing things and it's not having a specific effect, or it's not following what I would expect as far as a mechanical pattern, those things raise more flags for me to dig deeper into some of those more systemic questions or more concerning red flag type situations. Asking things about like the Canadian C-spine rules, and making sure that we're not, in an imaging situation where I might want to refer this patient back to the physician, or if they haven't seen a physician, refer them on to get imaging. Asking questions like our 5Ds and our 3Ns to rule down potential vascular things that could be mimicking, cervical artery dissection or cervical artery disease that could be contributing to a neck pain or headache type presentation. Those are all things that we can work on teasing out in the subjective exam, and would be the I don't want to miss those conditions when I'm going through my subjective, and I want to make sure I touch on those and ask about those to rule those things down before I would be comfortable moving forward with more into my objective exam and ultimately treatment.
So it would be, just to kind of recap from my own knowledge, because again, for those wondering, I was telling Anthony before we jumped on here, I treat very few necks. Now, if one of my patients happens to jump on here and listen to this, be comforted. I'm not an idiot with necks. I know what I'm doing, but I don't see a ton of necks. I see primarily lower quarter stuff. And so I'm recapping this stuff for my own benefit as well. So kind of some basic red flags are like, they've never had, this is a new type of headache. They're like, I've never had a headache that feels like this. Especially if it's like sharp stabbing pain in the neck or the head. It's really important to clear the Canadian C-spine rules, as well as look for other maybe more central issues with like the 5Ds and the 3Ns.
Yeah.
And I think it would be helpful to cover both of those for people who may not remember those off the top of their head. I am somewhat familiar with the Canadian C-spine rules. Sure. Would you be able to kind of just recap those for us? And for anyone listening, once he recaps them, I'm not really going to recap them, but I will include the link to the Canadian C-spine rules in the show notes.
Sounds good. Yeah, the Canadian C-spine rules are like basically like a clinical algorithm to determine which patients with neck pain and specific conditions.
I think you're cutting out. So go ahead and talk a little more to make sure it's good.
Are we good?
Yes, we're good. So you said it's an algorithm.
Yep. So it's kind of like a clinical prediction rule or a clinical algorithm to guide clinical decision making on patients that should be referred out for imaging with complaints of neck pain.
Got it.
Okay.
And if I remember it correctly, it gives some relatively specific indicators of who those people are.
Correct.
Would you mind going through those?
Sure.
The ones you can pop off.
Yeah. I have it down pretty good, but I did pull it up real quick. So age greater than or equal to 65 years old, a dangerous mechanism, which is spelled out, and paresthesias in the extremities. If they have any of those three things, we need to send them for imaging.
Got it.
And a dangerous mechanism is correct. Okay. And specifically, typically we want to see like that mouth open view where they can visualize the dens, right? So C2 and make sure that there's no fracture or anything there. Dangerous mechanism is spelled out: a fall greater than or equal to 3 feet or 5 stairs, an axial load to the head, like diving, that kind of an accident, a motor vehicle crash at high speed greater than 100 kilometers per hour. And I can never remember the conversion to miles. It's like 60. I think it's 60 or 65 or something like that. A rollover accident or an injection, and any type of like motorized recreational vehicle accident, like an ATV or a dirt bike or things like that, and any kind of bike accident, bike crash, bike collision with traffic or anything like that. That's considered a dangerous mechanism. So if you have any of those things, we want to send out for imaging. If you don't have any of those things, it moves to a low risk factor category, which has another few conditions listed: a simple rear end in a motor vehicle accident, that if they're able to sit in the emergency department, if they're ambulatory at any time, if they have delayed onset neck pain, and the absence of midline tenderness. If they have, if they're unable to do any of those things, like if any one of those things they have, you need to send them for imaging. If they're able to do all those things, you do not need to send for imaging. And then the last category and the last criteria is neck mobility. So if they're able to rotate their neck 45 degrees or more to the left or the right, if they're able to do that, you don't need to send for imaging. If they're unable to rotate their neck 45 degrees or more, send them for imaging.
Oh, interesting. Okay. Well, I'm going to, I have a question then, because I'm dealing with a neck patient right now, and it's an older lady, and she's quite the lady. She said some wild stuff in our clinic yesterday. I won't say anything that would tell anyone who she is, though. I'm too pretty to go to prison. But she's got some neck pain on the right, and she is like, can't turn my head to the right, and her mobility is absolute garbage. So that being said, with the Canadian C-spine rules, the fact that she's over 65 with severe neck pain, would that be a reason for me to send her to get an x-ray of her neck, or does it need to be multiple things?
So if you're in the Canadian C-spine rules don't apply in like non-traumatic cases.
Oh, got it. Okay.
Right. So you could be over 65 and have like 1 degree of rotation, but that doesn't mean you need to go have imaging of your neck. This is really for traumatic events. And it really, some more background on this rule is it was really developed for emergency rooms to determine when somebody showed up and was in an accident that one of those two categories, high risk or low risk, do we need to go and get it? And it saved a bunch of money for the health system that I was initially studied in, which was in Canada, given the Canadian C-spine rule. And so if it's non-traumatic, the Canadian C-spine rules don't apply.
Okay, good to know. Thank you. Yes, anyone who misunderstood that like I did, don't just be sending all your old people with neck pain to get x-rays. That would be inefficient use of the healthcare system.
100%.
And then again, covering the 5 Ds and the 3 Ns, I'll kind of rattle them off, and you can let me know what I'm missing. There's dysarthria, dysphagia, diplopia or double vision, drop attacks, and I don't know.
Dizziness.
Dizziness. Got it. Okay. And then the A is for ataxia.
Yep.
And then the 3 Ns are, I never forget, there's nausea.
Yep. Nystagmus.
Nystagmus, and what else?
Numbness.
And numbness. Okay, got it. And if those are I guess rather it's more indicative if multiple of those things are present. How many of those things need to be present for you to kind of raise an eyebrow?
It really depends on what the overall presentation is, because certainly sometimes we have I might have a patient who has cervicogenic headache and cervicogenic dizziness, where they could be dizzy and they might have some nausea related to the headache and the dizziness. And it's starting to pique my attention at that point, where again, it just increases the vigor that I'm going to go through my screening process to rule down any of those, a true red flag condition. And when I get to my objective exam, that's where things like checking blood pressure and doing a thorough cranial nerve exam and an upper quarter neuro exam, those are going to be then some of my objective tools to further rule down concerning red flag or neurological conditions that are outside of the scope or would require referral to another provider.
Okay. So specifically for the 5 Ds and 3 Ns, some things that if those are kind of setting off some alarms, you're kind of looking more at like a really in-depth cranial nerve exam, blood pressure, upper quarter neuro screen, just to make sure all of that looks pretty good. And if all of that clears out, it again rules down your concern with those particular symptoms.
Correct. And if we take a step back to what we were speaking about before, if I'm finding mechanical signs and I'm finding that there's clear ags and eases, it's making sense from a cervicogenic headache standpoint, and I'm ruling that up, and I'm working to rule down the red flag conditions. That gives me more confidence moving forward to that objective exam, where I'm going to continue to further try to rule down my red flag conditions and rule up my musculoskeletal hypothesis. I'm trying to prove myself right, but I'm also trying to prove myself wrong, right? I need to meet both of those conditions as I go through my exam, especially with something like a headache where some of the red flag conditions can be very concerning. I don't just want to assume, oh, this is musculoskeletal, I'll take care of it, and start plugging away at their neck with mobilizations or exercises or soft tissue work. I want to make sure that I've done my due diligence from a clinical reasoning and a critical thinking process to make sure that I am not leaning into my bias or my maybe pattern recognition or my recency bias of I've seen a bunch of these get better, I think I know what this is, and make sure that with each one of these patients I see, I'm going through that process of proving to myself that it's not a red flag condition to the best of my ability with my subjective exam, my objective exam, the questions, the 5Ds, the 3Ns, all the screening that we can do. And at the same time, proving that it fits that category or pattern through my, again, subjective exam and then clinical testing in the objective exam. So I'm trying to work it from both ends of prove myself right, but also fail to prove myself wrong.
Yeah. And I think and that makes sense to me. Like, I think that an important part of that would be to have a relatively consistent process that you go through when you look at it. So you're not just flying by the seat of your pants, just, leaning towards your bias to either, oh yeah, I can treat this, or your bias maybe because you're nervous to treat it about reasons to not see it.
Yeah, absolutely.
So what do you have a pretty consistent process that you do once you get to the objective portion?
I do. I have basically my own kind of like track or path that I want to go on. And then as I'm collecting the data that I need to complete my screening, and then also start to get into the point where I'm going to be at treatment and be directed and specific and precise as I can with that treatment, I'm trying to follow my path. And at any point, if I need to jump off that path and spend a little bit more time digging into some details, I'll do that. So typically I'm going to start right off with my typical in the clinic, how I would run it. I've got a patient running late. My next patient's coming in. I want to get through this quickly. I'm going to do a quick upper extremity kind of general range of motion just to see if there's any gross asymmetries. Does that trigger any pain? Is that different than what I would expect it to be? And then from there, I jump right into my cranial nerve screen. And so I'm going to run through a quick cranial nerve assessment. And if I see something that jumps out to me that would require me to slow down a little bit or dig a little deeper or retest that, I'll do that. And then from there, I'll start to get into range of motion. And I guess the other piece I would throw in there too is I would do blood pressure. Typically with a lot of these patients I see that are coming referred directly from my physician colleague that we work with, they've just had their blood pressure taken before they walk over to PT. So I check that in the chart just to get my eyes on it and make sure, like, okay, where was their blood pressure a half hour ago when they're in with doc? I see where it is. I know where that is. So I have that in my mind. If he did not see the patient or I'm seeing a patient that was not referred by him or from within our department, then I would take blood pressure as part of that as well. And then I jump into range of motion. And for me,
can I interrupt you for a second?
I'll pause there. Yeah, please do.
I'll jump in and I'll interrupt as needed to kind of see if I can address questions people may have. Being honest, I don't know. I mean, I know what bad blood pressure is. Like, why is blood pressure that important for headaches? Like, are you looking for if it's high enough that they could potentially have a stroke, or like, why is blood pressure important?
Well, it's really important, and not only in headaches, but I think with neck pain as well. If we look, and especially if you're planning on or incorporate or utilize any manual therapy, I would even argue whether you do manual therapy or not, the risk of having a stroke if you get your patient on the treadmill or the exercise bike is there, right? So we should be assessing their cardiovascular status. If we look at like there's a great document, the IFOMT guidelines that came out a few years ago on screening for cardiovascular or cervical artery disease and cervical artery dissection, gives a great overview of why it's important and how to appropriately screen. And it dives deep into questions and the subjective exam as being such an important part of that screening process for non-musculoskeletal conditions that can mimic musculoskeletal pain patterns, right? And that's even true to neck pain. If you look at some of those pictures in those studies, like you'll see like this is where a cervical artery dissection can present as pain, and it looks exactly like, hey, yeah, I have a tight upper trap in this area, or I have some mechanical neck pain. Like those things overlay each other. So it's very important that blood pressure is one of our objective exam measures that we can utilize to assess the integrity of the cardiovascular system. So it's another piece that we can use to say, yes, this person has a healthy cardiovascular system, and not that we can hang everything just on blood pressure. We have to have that detailed subjective exam and be thinking about those conditions even as we move forward in our objective exam. But it's one of our best tools to pull down cardiovascular involvement or their risk profile for being a cervical artery dissection or high risk stroke person that we might not want to do manual therapy on their neck, or contraindicated to do manual therapy on their neck, or we may need to refer them out depending on what we're finding.
Got it. So for anyone listening, I will include those IFOMT guidelines in the show notes. I'll find those for you. I'll hunt them down. I'll use ChatGPT to scour the internet. So after you said you do a quick upper extremity screen just to kind of see if anything is grossly abnormal. And then you're jumping into cranial nerve screens and blood pressure. And then you said you're going to jump into range of motion. Is that up the neck?
Yes.
Got it. I'll let you continue then.
Yep. So then my kind of track now is, okay, I'm into active range of motion of the neck. Now, some of the order of that I would do my range of motion in kind of is going to depend on what the irritability of the patient. So if they tell me, yeah, if I turn my head even just a little bit, it shoots off a 10 out of 10 headache, I'm probably not going to do that first. I would save that more towards the end. Now, if I have somebody more with like a lower level of severity and irritability, I typically want to dive right into rotation first, because rotation is, our upper cervical spine is responsible for most of that range of motion, or more than 50%, 45 degrees plus of that range of motion comes from that upper cervical spine. And we know that most cervicogenic headaches, or a lot of cervicogenic headaches, C0, C1, C2 is where those cervicogenics originate from. So that's where I want to know right away. Are you limited in rotation? Does rotation bring on any symptoms? Is rotation range of motion symmetrical or asymmetrical? These are all things that are giving me clues about where I'm going to go further in my exam. So I almost always start with rotation, because it gives me a lot of information about the area that I potentially have identified in the subjective exam as my main place that I want to check out in that upper cervical spine.
And
the other, go ahead.
I'll interrupt just for a second. So for people who don't know, the cervical spine is generally divided into two parts, upper and lower. And the upper cervical spine is the occiput, which is essentially the base of the skull. C1, which is the atlas, and C2, which is the axis. That's the upper cervical spine. And then C3 to C7 is considered the lower cervical spine, just in case anyone's like, upper cervical spine. So sorry, just plugging that in. Continue, Anthony.
No, absolutely. I love the basics and the fundamentals are what it's all about. It's good stuff. So the other thing I'm looking for at rotation is not only quantity and symptom reproduction, but quality, right? So a lot of times I'll see, hey, somebody will start to turn and they'll do this like compensatory side bend. Their brain is trying to get them to turn more. And in reality, they're kind of in this position where they're like way side bent over to the side. So do they get good, clean, pure rotation? Do they get all the way to end range? If they're lower severity irritability, I might get in there with a little overpressure and see what happens when I add a little overpressure in that direction, because that might potentially trigger off some headache or show a referral pattern that I'm interested in. So, and then I'll go through that with the rest of our planes of motion. So we'll look at extension, we'll look at flexion, we'll look at side bending. I'm looking for those comparable signs. What is causing you your neck pain or your headache, right? Are we reproducing your symptoms, or are we finding reproduction of stiffness and tightness and structures that would make sense that are contributing to your comparable sign, your symptoms, your asterisk signs that you're coming in with? Does that make sense so far?
Yeah, no, that is very concise so far.
Good.
I guess if someone does see, like, so let's say you turn your head to the left And you see
Yeah.
a lot of and you see a lot of side bending in either direction, where they either are trying to, go either direction with side bending with rotation. What is that kind of cueing you in on? Like, is it a structure? Is it a muscle? Like, what are you looking at when they see that you're like, huh? Or is it just piquing your interest to look more at the upper cervical spine when you do palpation?
Both. It's piquing my interest as an asterisk sign, so it's something that we can retest after.
Oh, got it.
And
Okay.
it's giving me a clue into like, ooh, when they try to turn, they do some funky stuff. So something with rotation, and then I'm thinking about the structures that contribute to rotation. If I go in there and find some restriction, some stiffness or reproduction once I get my hands on the spine, and they have some altered movement patterns or poor motor control or compensatory patterns when they're moving, now I'm just kind of stacking my puzzle pieces, right? I'm kind of finding like, okay, they don't move well in that range. When I get into manual, I find stiffness or reproductionist symptoms there. And now I can treat what I find with my hands and then come back and be able to see, did we change their movement pattern? Now they don't do that compensatory side bend as much. It doesn't reproduce as many symptoms. The last movement I wanted to mention that I check, and I usually save this one for last as well, is going to be protraction and retraction. So that's one that I see a lot of PTs sometimes miss, but very important with, I think with all neck pain, but especially with, I think cervicogenic, sliding that neck back into retraction is important to put some stretch on those suboccipitals and move those upper cervical joints. And that's another place where in all the planes, I would use overpressure if I need to, but that's a place where I'll come in, especially with retraction, and put a little overpressure on if needed. And then that pretty much concludes my active range of motion exam in the cervical spine. My next step from there is if they actively have a headache. So sometimes a patient is sitting there and they say, yes, I've got a 4 out of 10 headache. It feels like pressure and squeezing right here. When I turn this direction, it reproduced it. Maybe they had a little bit of a faulty movement pattern. The next thing I almost always do is I'm going to do a little bit of seated traction. And so I'm doing seated traction for a couple of reasons. I want to know that if I unload those joints mechanically, and I put maybe a nice gentle little stretch and take some of the work off those suboccipitals, deep neck flexors, and neck muscles, does that create an immediate change in their symptoms? Do they say, hey, that feels really nice on my neck. My headache is not as intense. Hey, actually, my headache goes away. Awesome. And then I let go of their head and we see, does it come right back? Like, what is the response to a little bit of traction? I really do that for 2 reasons. One, it's kind of confirming for me, yep, it's got to be mechanical. If I'm unloading their head and unweighting their head, taking pressure off joints and muscles, and they say, hey, I feel better, I'm like checking another box in my column that says this looks mechanical. And then the other thing I'm doing is I know that as I go through my exam, and through the rest of my exam and into my trial treatment and ultimately treatment, if I do anything that flares them up and makes them not feel good, I can go in my back pocket to traction, where I know that gave them some relief initially. So it's kind of fills multiple roles, that traction move for me. Sometimes it works great and they say, oh, wow, like my headache's almost gone. And sometimes it doesn't. And there's probably a bunch of different reasons why, but it's just a nice quick check for me that either says like, ooh, this is more likely to be a quick responder. This one might need a little bit more work. This one responded to traction or it didn't. And so it's another kind of box that I can check that gives me more information, mechanical versus not mechanical, quick responder versus maybe not as quick of a responder. And then from there, I'm going to move into supine, into the supine position to start my exam there.
So when you do the seated traction, I've always been curious about this. Do you prefer to be behind the patient or in front of the patient when you do that?
I typically am doing it from behind the patient.
Okay.
I feel like it gives me better control over the head. I put a little bit less pressure, I feel like, into their suboccipitals when I'm behind them. The one thing that I'll say though is I miss the opportunity to observe their eyes while I'm doing traction. So one of the things we talked about before was nystagmus, right? Or even just facial expression. So I do a lot of education before I go behind the patient. I tell them what to expect. I tell them what information I'm looking for and what I want them to pay attention to. So I literally will say to the patient, all I'm going to do next is do a little pull on your head. I want to know if it makes you feel better. And if it feels better, does it feel better in your neck? Does it feel better in your head? I want to know if it makes you feel worse. If you feel worse, I'm going to let go of your head and we'll talk about it. And if it doesn't feel like anything, it doesn't change anything, just tell me it feels like you're pulling on my head. And I make sure that they're clear. And then I'm going to go behind, do the test, and it sets expectations for them so they kind of know what I'm looking for. I'm not just don't just grab their head and start yanking on it and expect them to know what to tell me. So it lets them know what's coming and then makes it clear kind of what kind of information I want to know in response to that particular test.
Perfect. Thank you. Yeah, because I know people do it different ways, and like obviously it's like whatever you need to do to make it happen and do it proficiently to help you in your process is perfectly okay. But I've always been curious if there was really a limitation as far as not necessarily like just the fact that you can't observe, but I wasn't sure if you felt that being in the front, other than a little extra pressure on the suboccipitals, if you felt that one was better.
I think my pattern is just I do it from behind because I feel like I get better traction.
Right. So if someone else feels they get a better traction in a different position, that's fine. That's cool.
Absolutely. And the other point I would throw in there too is this process that I'm kind of talking through so far, I try to keep it pretty standard. So I'm doing it the same way or in the same order typically pretty much every time with some minor modifications based on presentation, severity, irritability. If the patient doesn't tolerate the seated position at all, I can do the whole exam laying down if we needed to. But because I do it in a very systematic way each time, it keeps me organized in my thought process, and it keeps me organized that when something pops up that's not what I expect or doesn't match with what my hypotheses were from my subjective exam, that it kind of raises that flag for me, and I step back and I say, okay, what do I need to reassess here? What do I need to dig in a little bit deeper if it's not matching where my hypotheses were leading me from the beginning of my exam?
Yeah, no, and I think that's what I think a lot of people, particularly young clinicians, are missing. Like the best thing you can do for yourself, and I think that's part of the benefit of doing a residency or a fellowship like Anthony did, is you learn a system from people who have already figured out systems. And so you kind of get to inherit that very early in your career, because I mean, I think we've all had it where it's like, you're like, I have these 10 things that I'm going to do. And as you go through them, if you don't go through them in the same order each time, like you'll get done and you'll be like, crap, I forgot to look at that, or I didn't do this, or I didn't do that. And things will fall through the cracks if you don't have a consistent system that you can run through efficiently that will cover enough of your bases to let you know that you are safe and heading in the right track with treatment. So once you lay them down, Anthony, what are you doing in supine?
Sure. So there's really two main things I'm doing in supine. And this is where we're going to kind of like go from, we did all this subjective exam, we did some of this stuff in sitting, and now it kind of gets a little bit faster because we're kind of funneling down and honing in to be precise in where we want to get to our treatment. Once I get them in supine, I'm going to do a quick assessment of soft tissue. So I'm feeling what the upper traps feel like. I might do a quick check there of like that first rib, scalenes, and then I'm going to work my way into a segmental exam. So I'm going to work from C7. And I start real low, even though I'm thinking that their issue is in upper cervical already. I'm going to start low just so they can feel my hands and I can feel what their reaction to my hands are. And then I'm going to quickly work my way up. So I'm going to start with a little side glide assessment from C7 and work my way all the way up to C1. I am communicating with the patient the whole time. I want to know if it feels different from right to left. I want to know if this is uncomfortable or causes your symptoms when I'm pushing on the spine, or does it radiate up into your head? Does it make you feel any of that dizziness that we talked about before? Does it make you feel any of the symptoms that you presented with initially? If anything changes while I'm pushing on your neck, I want to know. And I'm going to work that right versus left, right versus left. A lot of times I'll say to my patients, it's like you're at the eye doctor. Here's the right, here's the left. Does it feel different? Does it feel the same? Is that your symptom? Is it just pressure from me? And if I'm finding, typically what I'll find in somebody with a cervicogenic headache, as we get up to C2 or even up into C1, ooh, that's really stiff and sore. And I'm starting to feel a little pressure come on into my head. That's a very common complaint. Sometimes we get reproduction or increase in headache. Sometimes we don't. Sometimes I just find that they're really stiff in the joints that would refer up into the head. And so my fellowship program was very heavily based in Maitland, and so Maitland terminology is what I kind of default to. So that's a comparable sign and an appropriate structure. So even though I didn't reproduce the symptom, they were stiff in a structure that I would expect would reproduce the symptom. And that's what like, if they're just stiff, but it doesn't actually reproduce their headache, I'm still interested in trying to address that impairment and then retest all my asterisks and monitor their symptom behavior and see like, ooh, did we decrease the frequency, the duration of their headaches? And that's something we would check between sessions, especially if they didn't have a headache while we were hands-on there. So that's my segmental exam. If I'm not finding anything with side glide, I'll do more of an up glide to each joint to see if I find any stiffness there or if that reproduces any symptoms. And then from there, I'm going to move to my kind of one real special test here is going to be my cervical flexion and rotation test, is one that I'm always going to include. And that is to really do some structural differentiation. So I'm locking out the lower lumbar spine, maintaining that lower cervical spine, not lumbar spine, lower cervical spine, and then take them into end range rotation to put some mechanical stress on those upper segments. And it's another way for me to kind of now start to confirm, like, this is definitely upper cervical, and I'm targeting, is it right versus left, and really honing in on where I think I'm going to deliver potential manual therapy based on the findings of the exam so far.
So when you do the cervical flexion rotation test, I have also learned that you can do lateral, so you can do side bend with rotation.
Sure.
Well, I just wanted to make sure that you had, like, if you think that is also an appropriate approach, because I think some people may not feel super comfortable, like cramming someone's head clear up into their like chest and then rotating it, and so for like I mean, I can say from my experience, but I'd be curious to know your thoughts as well.
Yeah, I think the cervical flexion rotation test is more well spelled out and kind of tracked from a research perspective. So I think when possible, I always go with the cervical flexion rotation. The thing with cervical flexion rotation test is that I see people make a mistake with is that when they bring them up in flexion and start rotation, they lose some of the flexion. And you get a wishy-washy answer. You kind of you get some false negatives because you're not actually doing the test fully, where you maintain flexion all the way through rotation. That being said, and I've done this before, if I have a patient where like flexion really aggravates, or they have some additional neck strain or whiplash-related injury or upper thoracic stuff that is really painful for them to go into passive flexion, then I'm not going to jam that patient into flexion if they're really uncomfortable. That's where then I could do a little lockout in side bend and then check some upper cervical rotation there. So to me, it's like my backup option if for some reason I can't, or they're not comfortable or not able to go into that full cervical flexion position.
Okay, cool. Yeah. And for anyone who may not be familiar with what I'm saying, like if you just need to lock out the lower cervical spine to isolate upper cervical rotation in some way. What Anthony's saying is the most well-studied and the most common one in the research is the cervical flexion. So you lock it out with flexion before you do rotation, but it is also an option to fully side bend them and then rotate to the opposite direction as well to test that if they may be more sensitive to flexion or have other issues that you're like, I'm not sure I want to crank them into flexion with that kind of issue.
Sure.
And this may be, I mean, I think I already know the answer to this question, but I'm going to ask it anyways because I like to stir the pot. So what are your views on the ability for you to detect differences, palpable differences in joint mobility from side to side?
What I would say is, I think that it's a skill that you can get better at with practice and intentional practice and really paying attention to what you're doing. However, I also recognize from the research that's out there that we're not as specific as we think we can be. That being said, I always try to be as specific as I can, but I am much more reliant on what the patient's telling me than what I'm feeling. Meaning, if I feel a segment that's stiff or I perceive as stiff, but the patient is saying like, yeah, that feels fine. That doesn't reproduce anything. I don't feel anything there. I'm not convinced that that's an important segment necessarily for me to be super focused on. But if I have a segment that I have gone through my systematic evaluation and I feel, this side doesn't feel like it moves the same on this side, I am constantly communicating with the patient and asking for feedback. Does this feel the same as this? Does this feel different? How would you describe what this pressure feels like on this side versus this side? And I'm doing that eye doctor dance back and forth to have them give me the feedback if it's relevant or not. I am way more interested and way more excited if I find a segment that's stiff and the patient says, ooh, I really feel that right there where your pressure is, and I'm feeling that radiate up into my head. That's like my headache that I get. Now I'm sold that stiffness I'm feeling matters and is an area where I might want to target some treatment. But both of those things need to match up for me. And that's because I recognize that my ability and perception through my thumbs and my fingers and my hands and what I'm feeling from a stiffness standpoint is only relevant if it matters to the patient. And so when those two things come together and match up, now I think I have something clinically relevant to go after.
Sure. Yeah. So what it sounds kind of like you're saying is you are not solely reliant on what you feel or what you think you feel.
Mm-hmm.
You take into consideration what the patient is saying to you. However, also based on kind of the system that you have adopted through Maitland, it could also be that you may feel a stiff segment and the patient's like, no, I'm good. And you're like, that is not the same. And
Sure.
based on a relatively consistent pattern of presentation and treatment through the Maitland approach, I will also direct some attention to that.
Mm-hmm.
But that being said, it's because that specific joint hypomobility that I'm feeling is related to a system and not just like, oh, I think C6 is kind of stiff on the right, even though the patient's like, no, everything's good. Does that make sense? Or
it does make sense. It does make sense. And then even more important to bring it kind of full circle, and I want to definitely spend a few minutes on treatment before we run out of time. But
sure,
the thing that is most important to me, even in regards to everything we just said, whether they feel symptoms, they don't feel symptoms, I think it's stiff, but they're not really saying anything, is when we get up and retest our asterisk signs, did we make a change?
Right.
If I pushed on that segment that I felt was stiff and they get up and the patient says, wow, oh, wow, I can really rotate my head a lot more. Or wow, I don't get a headache now when I turn my head. Or hey, I'm not doing that compensatory side bend thing that we talked about before. Now I feel like, okay, I've got something that clinically meaningful and that is meaningful to the patient in terms of if they were complaining about limited mobility and headache that came on when they turned their head to the left, and now they don't have that. Now I've kind of like used my treatment and my retesting and my systematic process of testing my hypothesis and testing what the effect of my treatment was to kind of prove to myself that, hey, that was relevant and mattered. But I don't really know that it was relevant and mattered until I go back and retest it and retest those specific asterisk signs that I selected to match the specific condition that I'm trying to treat and approach.
Sure. No, I think that's a very concise summary. So I agree. Let's go over some treatment stuff. I think people will be very curious to know about that, especially from two standpoints. I think and you take all the time you need. I'll kind of interrupt if I have questions or clarifications, but I think I'd be really interested to know kind of what are the manual techniques that you find most useful in addressing upper cervical limitations or just cervical limitations generally, as well as what are you at least initially giving to people as far as homework.
Sure.
And I think because really we can't go into all the complexities of what's going through Anthony's brain when he sees someone, because he has years of experience and multiple reps under his belt, and he sees things intuitively that would be very difficult or take time to explain. And we don't have that time right now. So if we could talk what are your kind of go-to manual interventions and where do you generally start with self, exercise and stretches interventions, and then we'll wrap up. I think that would be super useful.
Perfect. And that sounds great. And I think the most thing I was kind of excited to get to and talk about is the treatment that I find to be most useful in the upper cervical spine is something that we all probably learn in Ortho 101 or cervical spine ortho class in PT school, is just our basic unilateral PA to C1 and C2. If we found that C1 and C2 were either referring symptoms or the patient felt really stiff and tight there, manually, I feel like they're real stiff and tight there. We've gone through that examination process. That's going to be my first line of treatment most of the time. And I'm going to spend some time on that joint. And I think for me, over the course of my career and the training that I've gone through and fellowship training, is I'm going to spend a good amount of time on that joint. And I want to hear what the patient's response is to that treatment. So again, I'm communicating with them frequently. Hey, does that feel like that soreness here that we felt when we were testing this joint? Yes. Okay, I'm going to hang out on that joint here. And I might spend 30 or 45 seconds on that joint. Every 10 or 15 seconds, I'm saying, hey, is anything changing? Do you feel that headache coming on? Are we reproducing the headache? Are we decreasing the headache? Is the soreness or stiffness that they feel under my thumbs increasing or decreasing? That is giving me feedback as to what the response to the treatment is. Mm-hmm. And if we both together, again, communication in collaboration with the patient, if I'm feeling like that joint is starting to move a little bit better and they're saying, hey, it was really sore when you first started pushing, but now it's not as sore, or that headache increased initially and now it's starting to actually decrease. I don't feel it as much. Great.
Right.
Now we're going to get up and let's retest our asterisk and see, like, hey, how does your neck rotation range of motion? Hey, is your headache any different now than it was before? If they were presenting with some of the cervicogenic dizziness signs, do you feel less of that dizzy or unsteady feeling that you had before? So that is my first line of treatment, is going to be our basic unilateral PAs to C1, C2, sometimes down to C3 if they need it. Now there's lots of nuance and variation, and that's where we can really dive deep into the details, and I'll save some of that certainly, but we can vary the angle. We can make sure we could go a little more medially or caudally or inferiorly directed with our forces. We can vary the grades of our mobilization, where if they're in a ton of pain, a little lower grade, if they're more just stiff, a little bit higher grade, and trying to push more into that end range. But that typically is going to be my first go-to treatment. The other thing we can do is we can put them into a little rotation and mode. We can take them out of rotation, so we can vary the position that they're in. So lots of options as far as how to vary it, but typically it's a basic, straightforward unilateral PA to C1 or C2, wherever we found was the most stiff and reproduce their symptoms. And I'm going to spend some time on that joint. How much time really depends on what the response is from the patient, and then we're going to get up and retest.
And do you prefer to do those in prone or in supine?
If they're able to tolerate prone, I like prone.
Okay.
There's a little bit of nuance and a little bit of like fine tuning to really make sure you're getting into C1. That's beyond the scope of what we're talking about right now. But if you have somebody that can show you, or you look up some videos or shoot me a message and I'll send you a video of how to really get into C1, it can be very effective and powerful to treat this particular condition for sure.
Great. Yeah, if you'd like, Anthony, is this like a video of you like doing a demonstration of how to get to C1?
Yeah, I could do something like that for you for sure.
Yeah, because if you would like, I would be happy to put that on, like if you want to put that on your Instagram, or if I can post it with the episode as like a little tip, I think that would be an awesome thing that people would be interested in seeing.
Yeah, I can show that, because that's the one part that just takes a little bit of finessing. But once you kind of understand how to get towards C1 and try to be as specific as you can, I find that helps it be a more effective treatment if you really need to get all the way up to that kind of top of the upper cervical spine. So that's my go-to first level kind of manual treatment. I will go to and utilize some upper cervical manipulation when needed, but it's not typically my first approach. And I don't typically do that on session 1. If they are not responding as I would expect, or we need to kind of bring in a little more vigor or force to the situation, then I might bring that out in session 2 or 3, depending on how they're responding. So that is part of my practice and part of my experience, but it's usually not my first line to go after. Yeah. And then from there, I'm typically following it up. I usually give 2. If I give 3 exercises, that's a lot. So I'm usually only giving 2. Let's say they responded really well to my unilateral PAs in that upper cervical spine. I'm going to give them some variation or version of upper cervical retraction with a little nod to create some space and movement in that upper cervical spine, some stretching in those suboccipitals. And I'm going to have them do it often. So I tell all my patients, like, I want you to do this 10 times a day. Every hour or so, I want you to get 5 to 10 of these chin tucks in. Very often, I'm going to teach them to go with some self overpressure to help them get further back into that range of motion and make sure they're really moving not just their lower and middle cervical spine, but getting all the way up to the upper cervical spine. Sometimes they'll tell me, like, ooh, when I do that, that makes me feel a little bit of a headache. And I'm saying, yes, that's good. Like, you're moving the stuff that is causing your headache. The more we move that and get that going, the better that's going to be for your outcome. The next exercise I'll give sometimes will depend on what their presentation was in terms of how limited were they with range of motion, how well did they respond to manual. So obviously, one of the kind of go-to moves that we see in the research and clinical practice guidelines is like a nice snag from Mulligan, where we're using a towel or a strap to be able to get some pressure into that upper cervical spine at end range to help kind of reproduce some of that manual pressure I was doing. And I find that to be very effective when treating these, especially if rotational range of motion was significantly limited. Then I was able to improve their cervical rotation range of motion within session. I then want to give them something to make sure they maintain and even further improve that range of motion before our next session. Mm-hmm. And so typically I'm going to send them home with that exercise, maybe 10 reps each direction, maybe a set or two or three times a day. And mm-hmm. then I typically tell these patients I don't want to see them back for about a week, because I want them to go and practice this stuff. And I want to see, okay, and how were they the first 2 or 3 days after we met? How were they the next 2 or 3 days? Are they doing their home exercises consistently? And that gives me a lot of information then when we get in on session 2 about how I may increase or change my manual therapy in terms of more vigor or less vigor, more aggressive or less aggressive, and then what types of exercises I might go to next. But from a first session standpoint,
oh, I may have lost you, Anthony. I don't hear you anymore. And your face is frozen. So we'll see. Yeah, I lost you. So for anyone listening, we're just going to see if we can get Anthony back on here. May need to shoot him a message real quick. Okay, we'll give him a minute or so. Oh, and I lost him. Looks like he may. We'll give him just a minute. It looks like he may be trying to jump back on. So I'll pause the recording and start it back up when he comes back. Okay, there we go. We are back. So as you were saying, Anthony, like a good place to start that first session is, especially if they're dealing with upper cervical issues, manual would be kind of C1, C2, UPAs. That's kind of bread and butter. You can modify those based on angle, head position, your grade, but you're definitely going to spend some time on those, maybe 30 to 45 seconds in each spot. But throughout that 30 to 45 seconds, you're constantly, every so often being like, how does that feel? Is it changing anything? Like, how is the patient experiencing that graded mob? And preferably in prone, if they can get to that position.
Sure.
For those of you who are unfamiliar with prone, like unilateral PAs of the spine, there are many videos online you can see that show that. It's not that you can't get to the spine and do mobilizations in supine. It's just that it's definitely not as easy. And the exercises you talked about, like chin tucks, retractions, especially with overpressure, a lot, like 5 to 10 per hour. And then especially if you just got regained some rotation, like reinforcing that rotation with kind of a few times a day, working that rotation and possibly doing snags.
Yep. Yeah, that's a pretty basic kind of. I hate to use the word cookie cutter, because it's not cookie cutter. It's all very well thought out, but that's right. A pretty typical package that comes with, if they had a positive response to those manual interventions, I want to get them moving. And there's lots of nuance, and it's going to be specifically tailored to that patient. There might be some different angles involved with our chin tucks, or some very specific like angles involved with those motions. But those are two of my go-to exercises for sure.
Excellent. Well, Anthony, I am very appreciative of your time. This has been very insightful for me as well. If you would just like to, I can't forget my question. Everyone's very curious, like what has been either a course or a book or a provider or website or person that you have just found to be fundamentally important to how you practice and who you are as a PT, that other people would maybe consider reading, attending, following?
Sure. Yeah. I mean, that's a huge question. I would say for me, having gone through residency and fellowship training, that the formal mentorship and engagement in like a rigorous program like that for me was practice changing, especially the fellowship when it comes to how to think systematically and be confident in your thinking. I think that really set me up to be able to, and I finished fellowship around as I was really ramping up and getting good at this particular topic area of cervicogenic headaches. And I really feel like having that very systematic framework and understanding of my own clinical reasoning and critical thinking has allowed me to develop a really good pattern with these patients where I feel like I really have a good handle on what's going on, and I'm confident in the decisions I'm making in the clinic. So in general, I would say that fellowship. And if I had to recommend, if somebody's not necessarily running out to go and do fellowship right now, if that's not part of your plans, that getting Maitland's textbook and reading through that, or taking a Maitland course can be a great place to start, or just working next to or talking to or reaching out to a therapist who treats in a particular framework that you find interesting or would like to try to see if that's a practice pattern or practice style that you would like. I think work with and ask questions of people who practice systematically, and it will help you become more systematic in your own way. And I think the cool thing for me about fellowship too is, like, as we go through that rigorous training process and complete the fellowship program, is you learn to kind of make the model and make the clinical decision-making framework your own. And that is where I find physical therapy has become even more fun for me, because I have that systematic place to kind of build and branch and grow off of, but I always can come back to. So right. That's what I would say is find a system that works for you, that matches with your kind of thought process and thinking style, but also helps prevent you from falling into ruts or biases. So that's my long, short answer.
No, excellent. And again, so for those who didn't hear initially, Anthony works at a place called Summit Health in New Jersey. Yep. And do you do any type of virtual consults? Do you teach any courses? Like, is there any way that people could, if anyone listens to this and like, man, Anthony is the man, like, is there any way that they could in any way work with you or interact with you? And it's okay if the answer is no.
I'm always happy to have I'm always happy to have a conversation and talk shop. Yeah. Give me a follow on Instagram or shoot me a message, and I'm happy to chat or talk or kind of talk through, like, hey, I really like the way you kind of think through things. Like, talk more specifically about where you are in your career. And if something like a fellowship is you want to look into, I always love talking to and kind of mentoring or helping kind of guide people to whether it's courses or meetups or chances to practice manual techniques or to discuss cases and things like that. I'm happy to do that kind of stuff. I don't have a lot of formal things going on currently, but I'm happy to chat. And, at some point in the future, I'd love to get into teaching, whether that be weekend courses or something online. But otherwise just kind of reach out directly to me, and we can chat and maybe see if we can get better at doing this thing together.
Awesome. So guys, for those who aren't watching, Anthony's Instagram is @Falco_DPT on Instagram, but I'll include it in the show notes so you can reach out to him as well. But again, Anthony, thank you so much for your time. And again, dude, appreciate you coming on, and I look forward to the next time we get to chat, and have you on.
Awesome. That sounds great. Thanks so much. And I can't believe like over an hour went by. It was fun talking shop and kind of talking about an area that I've gotten to be pretty good at. So thank you for the opportunity to share some of my experiences and for what you're doing with your show. I think it's great. And it's awesome stuff. I think the more we all can share together, the better we all get as PTs, the better, the whole profession is. So thank you for doing what you do as well.
Absolutely. And as always, guys, happy to have you.